Hello, good evening, everyone. So welcome back to another session of MCQ discussion. So as you already know, I'm Dr. Shahana and I'll be conducting you today's MCQ sample discussion as well. All right, so before we start, can you please let me know whether you can hear me as well as whether you can see the screen? Okay, thank you very much for that. I can see that few more people are still joining. But because of the time constraints, let's start. Anyway, you'll have the recording as well later. So for those who have joined, and we'll start now. All right. So I'm not going to brief you on how this will take place because we've already done one session. So this is your second session with me. So I hope we already know the way this is being conducted. So without further ado, let's move on to the questions. All right, so if you have any queries, you can put in the chat box. So this is your first question for today. Here you have a 68-year-old male undergoes a transurethral resection of the prostate, or TURP, for benign prostatic hyperplasia. Post-operatively, he develops confusion, nausea, and seizures. His serum sodium level is found to be significantly decreased. What is the most likely cause of his symptoms? A. Acute urinary retention. B. Cerebral vascular accident. C. TURP syndrome. D. Benign prostatic hyperplasia exacerbation. E. PSA rebound effect. Okay, I'll give you a couple of seconds to come up with the answer. This is an easy question. Let's see. Okay, so I can see that most of you think the answer is C, but there are only few responses that I can see in the chat box. So I would prefer if all of you can try your best to respond, because as I told in the last class, if you get it right, that's okay. But if you get it wrong, that's even better, because then you will learn a lot. So I would prefer all of you to respond. But anyway, let's see now here. All of you think this is TURP syndrome, which is actually very correct. So we have a 68-year-old male here. He's undergoing TURP, or transurethral resection of prostate, for benign prostatic hyperplasia. He develops this confusion, nausea, and seizures. Serum sodium level is found to be significantly decreased. So now we know the cause for all of his symptoms with low sodium as well. What is the most likely cause? So this is very easy. After TURP, or transurethral resection of prostate, we know TURP syndrome is the most common complication. So what happens here, as all of you know, there is there is an absorption of the irrigation fluid. So this will cause a situation of a dilution, and here the patient can present with hypotonic symptoms. So he will have dilutional hyponatremia, hyposmolarity, and this will result in severe neurological symptoms. Okay, so hyponatremia will give rise to all the symptoms that we saw in this case. And they can also have acute intravascular hemolysis as well. So first, the diagnosis is the most important thing, and the treatment is arranged accordingly. Okay, so usually what we use is your loop diuretic, which is furosemide, or there are other management options as well. So this gives a nice overview of the clinical common presentation of TURP syndrome, its clinical features, how to manage it, etc. So this could be used as a very good note for your reference on TURP. So this patient, as we can see, is coming with TURP syndrome. All of you said it very correctly. But let's go through the other options. Here we have acute urinary retention. Now you know when a patient is having acute urinary retention, the presentation is not like this. He will present mainly with anuria or oliguria, mainly anuria. Cerebral vascular accident can explain confusion and seizures, but hyponatremia, it can happen as a result of SIADH, which can happen, but that will take a lot of time. So this is an acute event that can occur, which is a stroke, and it will take a long time after stroke for SIADH if it happens to develop. It's not a very common thing as well. So it's out here. And you have BPH exacerbation that will not present like this. He will have mainly obstructive symptoms. And this prostate-specific antigen rebound effect means, especially after brachytherapy or radiotherapy, these patients can have increased prostate PSA, which will later become normalized. So that is completely different thing. So that's also wrong. So like all of you said, it is transurethral resection syndrome or TURP syndrome. Okay. So the correct answer is that. All right. Then let's move on to the next question. Mother postpartum 2 weeks, insomnia and sleep decrease, not carrying the baby, ignoring, but not harming the baby. No previous history of psychiatric diseases. What is your diagnosis? A, postpartum depression, B, postpartum psychosis, C, postpartum blue. Okay. So, very good. There is a question, I think. How much time it takes to develop TURP syndrome? Actually, it can develop even when you are just as soon as the irrigation is being happening, but as soon as the surgical procedure is over, till up to about 24 hours late even. Sometimes there are reports where it has developed while the procedure is being like 15 minutes of starting irrigation. So it's a very acute thing. But it can develop as late as 24 hours also. Usually it's an acute thing. Even if it's 24 hours, still it's an acute thing. So just after the procedure till about 24 hours, it can develop. Even during, sometimes, even after initiation of irrigation, after about 15 minutes, there are reports of developing TURP syndrome. All right. So here, I can see the answers are being varied among C and A. Okay, so some people think this is postpartum depression and something it's postpartum blues. And I can see a lot of you have responded, which is very good. And thank you for that, because then this discussion becomes interesting. Okay, so here we have a mother, postpartum 2 weeks, insomnia, sleep decrease, not carrying the baby, ignoring the baby, but not harming the baby. Okay, no previous history of psychiatric diseases, diagnosis. So we have for answers, we have the most three like common presentation of postpartum psychiatric disorders. Now we know postpartum mental disorders or psychiatric disorders, we have like three common things. That is from mild to moderate, your postpartum blues, postpartum depression, and postpartum psychosis. So we have three of them, all three of them here as answers. So now we need to be very careful to differentiate which is which, so that we'll mark the correct answer here. Okay, can anybody mention two important things in this case that will help you to come to a differential diagnosis, not differential diagnosis here. Two important key things before I discuss on these three. Can anybody mention? Excellent. One, Dr. Shabab, I think. Very good. Excellent. Duration is very, very important. Excellent. That is one thing. And another one is, I think Dr. Many of you have replied actually. Dr. Ayesh, I think. Not harming the baby. That is also very important. Okay. So these two are like key features that will tell you to help you to differentiate like which is which. Okay. So let's see how it will help you to differentiate which is which. All right. So let me take you to this. Now you can see this gives a comprehensive overview, a nice overview of the postpartum psychiatric disorders actually. All right. So like how to diagnose and etc. Now here you have the three different conditions. Now here you can see the postpartum blues, then you have the postpartum depression, and you have the postpartum psychosis. Okay. Three most common things. So when you take postpartum blues, these are like baby blues. These are very common, like all of you must be already knowing. This is very common, like most of the women will, about 85% will have this. Now this usually happens in the first few days. It will peak around 3 to 5 days usually, or can occur up to 10 days. And the symptoms will not interfere with the general well-being. And it is like general like mood swings sort of a thing. Okay. Then when you go to postpartum depression, now this is a bit severe than postpartum blues. Not everybody will have it. Now it usually happens from few days to actually few weeks following delivery. Generally in the first 2 to 3 months. So it will take weeks for postpartum depression to develop. But here the important thing is here the mother will have feelings of guilt or inadequacy about caring for the infant. Like she will have like obsessive like features that she is not caring for the baby and the care she gives is not enough. Some sort of a thing will be there in postpartum depression. Okay, now I'm telling only the key features because it will take a lot of time to discuss everything. You can go through this later. So when you take postpartum psychosis, it will also happen within the first 2 weeks following delivery. But here, the important thing is the patient will have psychotic symptoms usually. So he will have delusions, she will have delusions, some might have hallucinations as well. And here they will have like thoughts of harming the baby, mood swings, and this delusion, because of these delusions and all, she will have thoughts of harming, and actually this is associated with infanticide and suicide as well. So those three are the main key features of these things. Now, this article gives you a nice view of how to diagnose and how to treat pharmacotherapy and everything. And it's a very short one. So it will only up to this, nothing much. So it will help you if you, after the class, you can go through this and have a comprehensive overview. But for the MCQ purposes, just remember postpartum blues, it's like a mild thing. It will usually develop within few days. And the thoughts are like increased stress features. So this is unlikely here because she has not caring for the baby, ignoring sleep issues and everything. These two features, not caring for the baby and ignoring, points us towards less, makes us think of postpartum blues as less likely. Now, when you take post and the duration, like I just told earlier, then postpartum depression and psychosis, they can happen in first 2 weeks, but she doesn't have any thoughts of harming the baby. No mention about delusion or hallucination is also there. So postpartum psychosis is unlikely here. So with that, but then when we take postpartum depression, it can explain everything. Duration is correct, and this thought of not caring for the baby, ignoring those things are like very common in postpartum depression. So this is a very common scenario of postpartum depression. And the answer should be answer A. So please remember, like whenever you have a postpartum psychiatric disorder scenario, pay attention to the duration as well as to the symptoms and check whether there are symptoms of hallucination or delusion. If so, it is a very jolly well case of postpartum psychosis. Okay, I hope that overview was enough for this question because, like I said earlier, we are not going to discuss it deep into the theory. So this you can go through leisurely after the class. Okay, let's all right, but there's a question, but in depression, there was a history of previous depressive illness. Not always. Not always. Mothers who didn't have a previous history of depression can still develop postpartum depression. But when you take the two categories, the ones with previous history of depression as A and ones without previous depression as B, those with previous depression have a high chance of developing postpartum depression. But it's not them always. Those who didn't have a history of depression can also develop postpartum depression. So that can happen. Okay, I hope you got it. All right, now here we have a 4-year-old boy, anal region itchiness and redness with streaks of blood on stool. What is your diagnosis? A, anal thrush, B, streptococcus infection, C, pinworm. Now these questions are incomplete, like I told you earlier, but we are going to learn like how to work with the things we have. The main focus of these discussions will be to learn the areas that you get most of the questions and to like learn how to logically work out the answers. So let's see, try responding as much as possible. What do you think? Is this anal thrush, streptococcus infection or pinworm? Okay, so I can see a confusion between A and C here. Something this is anal thrush and something this is pinworm infection. Nobody thinks this is streptococcus infection. That is actually very good because here we have a 4-year-old boy coming with anal region itchiness and redness with streaks of blood on stool. Okay, so streptococcus infection will not present like this. So it's out actually, obviously. So now we are left with anal thrush and pinworm. Okay, so now what will help us to differentiate whether this is anal thrush or pinworm? So let's take itchiness and redness can be present in both anal thrush and pinworm. So what is the most important clue here? Not most important actually, an important clue here that will help you to like come to diagnosis. Yes, very good, excellent. One is blood. Another thing, that's not like exclusively, it will not tell exclusively this is pinworm. Very good, Dr. Very good. Age. Now this is the preschool age, right? 4-year-old boy is a preschool age. They are very common to get this pinworm infection. But as I told, it's not exclusive. Like whenever that's a 4-year-old boy, you can't say it is pinworm until proven otherwise. You can't tell like that. But it is supportive. Okay, so how do you explain this blood on stool? Now, this is a very good case of pinworm. Actually, the answer is answer C. This is pinworm infection. So, how do you explain blood on stool? Streaks of blood on stool, how do you explain? With pinworm infection. Can anybody explain that? Now, usually we know when you have pinworm infection, I will take you to that until you respond. Yes, very correct, very correct, very good. Itchiness is one cause which can produce blood on stool. What is the other thing? How else can you explain? Itching is the most common thing. Yes, very good. Due to itching, they can get that area injured and they can have streaks of blood on stool. Very good. That is the common thing. But there is another thing. Now, sometimes very severe infection can lead to formation of anal fissures as well. Pinworm. So that can also cause blood in streaks of blood in stool. That is the second explanation. But the most common one would be the blood due to itchiness. So this is your reference for pinworm infection. You have a nice overview of like the clinical features, the diagnosis, and the public health significance and everything in a nice point form view. Only a very small but a very informative article which gives you the overview of pinworm infection. So this I have included as the reference for you all. But even if you don't read it, that's fine actually, because pinworm infection, I think all of you know, is a very common infection in preschool children, and the main presentation is anal region, itchiness and redness, and you can find this egg of this worm as well when you examine. Okay, and you know the treatment as well. You have your, what is the treatment? Can anybody mention? The treatment of pinworm infections for the completion sake? You have your antihelminthic. What is the most important? Yes, very good, excellent. Your albendazole. Very good. So you have everything here. Preventive measure, treatment and everything. Okay, so I hope it was clear, nothing much there, and it's a straightforward one. So the treatment agent will depend on the age and the other factors as well. All right, you can go through it later. Next one, anaphylaxis child. What is the most striking feature? A, stridor, B, wheeze, C, impending doom, D, some other not so severe anaphylaxis features. So this was how that person has remembered it, okay? So that's why I have included it as it is. What do you think? Now this question is not difficult, but I expect like 2 answers to be coming from the audience. If there is a confusion. If not, that's great actually. So what do you think? Is it A, stridor, B, wheeze, C, impending doom, D, some other not, so some other features? Okay, and I can see most of you are now responding. Thank you for that. And that's very good. Okay, so as I expected, there's a confusion between A and B, stridor, wheeze. I can see few of you are thinking of impending doom as well. Now this nobody had thought because that's obviously wrong. Okay, so what is it? Is it stridor, wheeze, or impending doom? Can anybody mention? Now impending doom is a feeling, right? So impending doom is a feeling. They are asking most striking feature here. So before I come to this answer, let me take you to the reference of anaphylaxis. So this is your reference for anaphylaxis. This is actually the guideline by the Australian Society of Immunology, actually. Australian Immunological Society. I hope it's still loading, yeah. Australian Society of Clinical Immunology, and they have this guideline for acute management of anaphylaxis. So this is your reference for that. Now they have the definition here. Now as all of you know, anaphylaxis we defined as involvement of, we remember it as, now there are 3 systems, your skin, respiratory and cardiovascular. If you have involvement of about 2 systems, then that you consider as anaphylaxis. Now they have a different, not different, exact same, but differently worded definition, and their definition is here, which you can go through later. Then the symptoms are there, your respiratory symptoms, cardiovascular, and the GI can also involve. Now here, this is the most important thing. Now here you have the signs and symptoms. This is for allergic reaction, and this is the anaphylaxis part. So these signs, you have difficulty or noisy breathing, swelling of tongue, swelling or tightness in throat, wheeze or persistent cough, dizziness, pale, floppy, etc., etc. And then you have like how to manage it in a nice, like a summary like form, how to manage the anaphylaxis. Then you have the doses, like ephedrine or your epinephrine doses. Then management of anaphylaxis in pregnancy and infants. The differences are here, and the positioning, etc., etc., and the adrenaline, everything is there. And the advanced management for refractory anaphylaxis is also there. So it's about 9 to 10 pages, but everything that you need to know about anaphylaxis is here. So I would highly recommend you all to go through this and have an understanding. So my question now is, now here you have difficulty or noisy breathing, that is your stridor. Wheeze or persistent cough is also there. Okay, both are there. So keep it in mind. Now let's go back to our case. Now we have impending doom actually is not a very good answer here. Why? We need a more striking feature. Now, okay, can anybody mention why is impending doom not a feature here? Now, when I get an anaphylaxis, I might feel as something is going to happen and I'm going to die, and I might get a little bit of feeling as an impending doom. But it's not the answer here. Why is that? Can anybody mention? Because there were some who thought it's answer C. Excellent, Dr. Tilini. One thing is, this is a child. Child can't explain about an impending doom. For a child, everything will be like impending doom. Very good. That is one. And the second thing, this is a subjective thing. Now, we don't go by subjective features whenever there is an objective feature. So as clinician, we always look for objective findings. So impending doom is subjective to the person. For a child, everything will feel like impending doom. So that is wrong. Then out of stridor and wheeze, now most of you had voted for stridor. Actually, that is the correct answer. Stridor is the answer here. So why not wheeze? Because in the guideline you had both stridor and wheeze. So why do I say stridor is the correct one and not wheeze here? Can anybody answer that question? Why is it stridor and not wheeze? Because both were there as respiratory symptoms in the guideline. Yes, very good. Excellent. I think Dr. Shabab. Because of the word here, most striking feature. They're asking you the most striking feature. So when you take stridor and the wheeze, the most striking feature would be your stridor, not the wheeze. Okay. So that's why we go with answer A here and not answer B, because it will tell about an impending airway obstruction. All right. So that's how you get the answer A and not B, but both can happen in anaphylaxis. Because of this term, most striking feature, you are going by stridor. All right. So you can go through this guideline leisurely later and have an understanding of anaphylaxis. Let's move on to the next question. 14-year-old male lost weight in few months, very picky over his diet, only eats certain food, no other positive examination. A, OCD. OCD means obsessive compulsive disorder. B, ARFID, avoidant restrictive food intake disorder. C, depression. D, anxiety. What do you think? Now, in the original question, these were the only answers that were there in the question I got. But if you had an option E as anorexia, if there's anybody who thinks this is anorexia nervosa, they can vote as E. It was not there, so I didn't put it. But some might think of that as well. So if anybody thinks this is anorexia nervosa, answer E. Take it as answer E and put that as well. No problem. Okay. Okay, so I can see most of you think this is B, which is your ARFID. Some of you think it's A or C, D, and there were a few who thought of my answer, which was answer E. Let's see. Now you have a 14-year-old male. He has lost weight in few months. Very picky over his diet. Only eats certain food, no other positive examination. Okay, now let's go through the answers. We have OCD, that is your obsessive compulsive disorder. This is not OCD because in OCD you have obsessions as well as compulsions. Obsessive as well as compulsions, that means you have an obsession over cleanliness and the compulsion would be to clean your hands or wash your hands. So here you don't see any obsession or compulsion, so OCD is not an answer here. Let's keep this aside. Depression. Now, this is not depression. You have core features of low mood, low energy, lack of sleep, and those things. And you have anhedonia, those features. Nothing is there about that. So, this is not depression. Anxiety is also out here because you don't see any anxiety symptoms here. So, you are left with only avoidant restrictive food intake disorder. But I just gave an answer of anorexia as well. So again, my question is like in this question, what is the most important clue here that will help you to differentiate or that will help you to come to the answer? If my answer E was also there, anorexia was also there. It's not there, so it's very easy, but we have to learn if it was there. Very good, excellent. I think Dr. Sashu, I can't read the name. So very picky over his diet is the most important clue here. And he only eats certain food. Let's see. Now let me take you to this, which is your guideline for the, not guideline actually. This is a nice article which gives you the DSM-5. Now this is the DSM-5 is the criteria that you need to know for psychiatric disorders. Now this is about 5 or 9 page one. It gives you like the summary of the DSM-5 criteria for the eating disorders. You have your anorexia nervosa, bulimia, binge eating disorder, pica, rumination disorder, avoidant restrictive food intake disorder. There was a question in the chat box whether both are same, whether anorexia and this ARFID are same. No, they are not. They are two different types. Then you would see you have a lot of eating disorder types, about 9 are there. And this gives you like the diagnostic criteria of each. Now for anorexia, you have only one page. For bulimia, you can see only one page. Eating disorder, binge eating disorder, likewise. For each, the diagnostic criteria is nicely given. So this is a very good one. I would recommend you to go through this. So have a save this somewhere in your phone or your laptop or somewhere. You can refer this because it nicely gives the diagnostic criteria without giving too much information. When you have a lot of information also, it's confusing because of the time constraint. So you can go through this later. Here I have included the criteria for this avoidant or restrictive food intake disorder. Now here they have eating or feeding disturbances. They have like specific pickiness for different types of foods. They will prefer some food and some not. And they have this significant weight loss, nutritional deficiency, and everything else that is relevant to the this lack of proper intake of food as well. Okay, so what differentiate it? One thing is this picky over his diet. So what is an important feature that is found in anorexia and not in ARFID? Can anybody mention? Not the pickiness. One important thing that we always look in anorexia. Okay, I will tell. That would be that the thought or their high obsession of their weight, that they think that they are very fat and they have this conception, a misconception about their body image. That is not there in ARFID. They will have, but not so severe as anorexia. And they will restrict their food severely, and anorexia is a severe form of eating disorder. Okay, so whatever, now you can go through that guideline and actually differentiate the different things. Here the answer would be answer B, which is your ARFID, or avoidant restrictive food intake disorder. Okay, let's quickly move on to the next question. 25-year-old lady with dyspareunia since started having sexual relationship with partner 1. BMI 38, examination of vagina normal, no discharge or bleeding or foul smell, posterior fornix tender, lateral fornix is normal. What could be found? A, adipose tissue, B, chronic PID, C, endometriosis. What do you think? Okay, most of you think this is answer C, endometriosis. All right. Some think it's answer A, adipose tissue. Nobody thinks this is PID. So let's see, we have a 25-year-old lady with dyspareunia since started having sexual relationship with one partner. BMI is 38. Examination of vagina normal. No discharge or bleeding or foul smell. Posterior fornix tender. Lateral fornices normal. What could be found? Okay, now most of you said the answer is answer C, which is endometriosis. So there's a concern. Nobody thought this is chronic PID. Okay, that's not a concern. Nobody thought it is chronic PID. Can anybody mention two important things in this history that tells you this is not PID? What are those two? Because you need to learn that. Now that is the art of MCQ answering. Excellent, Dr. Tilini, I think. No discharge or bleeding or foul smell. Very good. In PID, you usually get a foul smelling discharge. Very good. What is the other thing? Age, yes. Okay, all right. Foul smelling discharge is like the characteristic thing that will tell you this is not PID, because in PID you have a discharge. Pain only during intercourse, very good. Yes, that is also supportive, because in chronic PID you can have not only dyspareunia, you can have low abdominal pain like presenting, but that's all right. There's another important thing in examination. Yes, with only one partner. Yes. So that is not exclusive, but usually in PID you will have your lateral fornices also being tender. And your this cervical excitation will also be positive. Cervical excitation test. Posterior fornix only the posterior fornix being tender is also a bit against PID, but that's not like exclusive. The most important feature is this one, no discharge, bleeding or foul smelling. So that you all have figured out. Very good. So adipose tissue is wrong here, because that's obviously will not explain any of this. PID is out. So answer C, endometriosis, is actually correct. That's very good. Okay, so when you take your dyspareunia, you have these differential diagnoses. These are like the common causes of your dyspareunia. Your PID and endometriosis being like very common ones. But just because we are on the topic of dyspareunia in this MCQ, remember you have two types. I think you already know. You have your deep dyspareunia and the superficial dyspareunia. So this is not given in the case we have. They have not mentioned whether it is superficial or deep. But since they have asked this, maybe in your exam you might get a question where they will tell whether it's superficial or deep and ask you to like differentiate. So just remember superficial, they are commonly in patients with vulvodynia, vaginismus, vestibulodynia, mostly like superficial or outward structures. Deep dyspareunia, it's usually you get it when you have pelvic involvement, pelvic infection, PID, tumors, endometriosis, etc. So just have an overview of different causes of dyspareunia, and remember like which will cause superficial and which will cause deep. Now, for the sake of your endometriosis, now this will be your reference for endometriosis. Now, I'm not going to discuss it, but I thought it'll be good if I like show you what you have to go through to have an understanding of the endometriosis. So this will be still loading. This will be your RSVGP article actually. Okay, this has the update. This is the update of endometriosis. So it will give you the clinical features, diagnosis, examination, and the treatment, empirical, pharmacological, surgery, and the different methods of treatment, and the findings, those things. So this article is actually of 4 pages, but this is enough for you to have an understanding understanding of endometriosis for your exam purposes. So please go through this if you haven't already and have an idea of that. Okay, next question. Lady in 37 weeks of pregnancy, RH negative, examination SFH, that is symphysiofundal height 33, fetal parts easily palpable, first trimester scan normal. What is the cause? A, renal agenesis, B, hydrops, C, wrong dates, D, engagement. What do you think? Okay, so let's see. There's a division of answers among, actually there's a mixture of answers. So we have answer A, B, C, D, all are there. So let's see how do we approach this question. So here we have a lady in 37 weeks of pregnancy. Not nearly, actually term pregnancy. RH negative. Examination SFH 33. Fetal parts easily palpable. First trimester scan normal. What is the cause? So here we have actually fundus less than dates. So if we like tell it as a category, this SFH is way less than the date. Usually when it comes to the third trimester, about plus or minus 2 to 3 would we would consider all right. But here see, this is 37, this is 33. Okay, so there is a discrepancy of the POA and the SFH. So this is fundus less than dates. So you should know the causes for fundus less than dates. Okay, let me take you to that. Now pay attention to this. If the uterus is small for date, you have to think in terms of these three lines. Whether it's wrong dates, whether it is oligohydramnios, that means lack of LICO or less LICO, or whether there is a component of IUGR or intrauterine growth retardation. So these three are the broad categories that you have to think when you have a uterus less is small for the gestational age or small for days. Okay, so if you think in that terms, it will be very easy. So whether the dates are wrong, whether it's oligohydramnios because of lack of LICO, or whether it is IUGR. Now going back to our case. Now here we have answers renal agenesis, that is a cause for oligohydramnios, so we can keep it. Hydrops is a cause for polyhydramnios. Now polyhydramnios cannot explain this discrepancy, so that's out here. Wrong dates, again we have to keep it because that's a cause for fundus less than dates. Then engagement, okay. Now engagement happens when the fetus approaches term, but engagement will not. It has some time, but engagement will not cause this much of a discrepancy in SFH actually. So that is not the answer here. That's also wrong. So we are left out with renal agenesis and wrong dates. Okay. So what is the clue? There is a clue in this case which tells you that this is oligohydramnios, wrong dates. Excellent. Dr. Maria, I think, if I'm pronouncing it correctly. Fetal parts easily palpable. Very good. Excellent. That is the clue that you have here. When you have fetal parts easily palpable means that tells you that the LICO is not enough. If the LICO was adequate, you can't easily feel all the fetal parts. You will feel the head, you will feel the buttocks, you will feel some back canal, but you will not feel all the fetal parts easily. This is the clue that tells you that LICO is not adequate. There is another clue. I'm sorry. Yeah, this is the important thing that will tell you this is inadequate LICO for oligohydramnios. So very good. That is the answer. So, and first trimester scan normal, that is okay, but it will not tell about the dates actually. Now, dating scan should be done at 8 to 12 weeks. They have not told when it was done. So we don't know like whether it's wrong dates or not. But this will guide us telling that there is a problem with the LICO. Okay. So this is a case of oligohydramnios. So now this is a nice chart that helps you differentiate oligohydramnios and polyhydramnios. The definition, etiology, diagnosis, treatment, etc. Everything is nicely there. So you know oligohydramnios, there's a problem with either absorption of there is excessive absorption of the LICO, and actually there is no putting of LICO out from the baby. So that is due to renal problems. So renal agenesis is the correct answer here. So the babies must be having renal agenesis. So not putting out enough LICO out. So there is a discrepancy of this SFH. Okay, so whenever you have a small fundus date, think in this term, whether it's a wrong date, whether it's due to lack of LICO, oligohydramnios, whether there's something relevant to IUGR. Okay, I hope I made it clear. So you can go through this leisurely later. Next one. There's a question, I'll answer it. Others, until that, others please go through this answer. Previously well young man has recently history of suppurating and painful axillary lymph node. What is the diagnosis actually? So this is not A. A, cat scratch disease. B, hidradenitis suppurativa. C, toxoplasmosis. The question that I told was, isn't first trimester and dating scan same? Yeah, they are same. First trimester scan is normal, but the dating scan, for it to be accurate, it should be done in the window of 8 to 12 weeks. Some they do the first trimester scan later. Sometimes the patients present later to the first trimester scan. Sometimes they come too early. then though the scan is normal, the date might be interpreted wrongly. So dates might be wrong. So the date of first trimester scan is not given here. Okay, so that's why with the term first trimester scan normal itself, we can't tell this is not wrong dates. But maybe they are trying to imply it in the original question that was there. But first trimester scan normal and the dates being correct for you to tell that the time when the first trimester scan was done is important. Okay, so here we have I will give you some more time for to respond this question. There are only few answers yet. Okay, most of you think this is answer B, hydrogenized suppurativa. But there are few who thinks it's answer C, toxoplasmosis. And few things think it's answer A. Sorry, there's this misnumbering. Here answer A is cat scratch, answer B is hydradenitis suppurativa, answer C is toxoplasmosis. Okay, so maybe because of that only that confusion was there. So here let's see what do we have. We have a previously well young man, recently history of suppurating and painful axillary lymph node diagnosis. Okay, so whenever you have a history of suppurating and painful axillary lymph node, let's take cat scratch disease, hydradenitis suppurativa. Now, this history given here is actually not very adequate. You need to have more information. But with only the given information, we can come to one answer. I'll explain how. Now, when we take cat scratch disease, it is a disease caused by actually your Bartonella hensei, that by microbiome. It usually is transmitted by your cats. Whenever they have a cat scratch, a scratching of the cats, initially in the place of scratching of the cats, they develop like a blister sort of a thing. And then they will start developing regional lymphadenopathy. So that is how the natural history of cat scratch disease happened. But here nothing has been said about a cat bite or any blister or some sort of a thing at the soft bite site. So cat scratch disease is unlikely. Hydradenitis suppurativa, yes, it is correct because it usually presents with suppurating and painful axillary lymph nodes. So this presentation is like fits to hydradenitis suppurativa. Now toxoplasmosis will not present like this. It's completely a different thing, different sort of an infection. I think you must be already knowing. So here your answer is correct. Actually, it is hydradenitis suppurativa. So let me take you to like the overview of this hydradenitis suppurativa. Now this hydradenitis disease being repeatedly asked. This is not the first time that we came across this question. So that tells you that you should have an idea about this. So here, this is your reference for hydradenitis suppurativa. It tells you like what is the diagnosis, how to diagnose it, epidemiology, the clinical findings. You don't need to worry about these gradings. No need of those. Just the clinical findings. And these are the lesions that you get actually. These are axillary lesions, like you can see. Okay, and the management options are there. Surgical management and the pharmacological and the wound care and everything. So this is about 4 pages, but gives you all the necessary information that you need to know about hydradenitis. No need to go through these gradings. Learn about the clinical features, investigation, and the management, specifically to identify. Okay, so this will be your reference. All right, moving on. 18-year-old girl unconscious, unconscious in a bag with white no-name tablets. She has pinpoint PUP. Okay, 18-year-old girl is unconscious. In her bag, there are white tablets without name. She has pinpoint pupils. Okay. What do you think? Okay, now there are two questions. Just read clinical features and treatments then. Yes, just have an overview of what it is, what are the clinical features, and it's actually a clinical diagnosis, and what do you do give for treatment. A small summary will be enough. What is the cause of hidradenitis suppurativa? It's usually due to obstruction of the hair follicles. And then it will enlarge and rupture and cause an inflammatory reaction actually. Hair follicle obstruction. Okay, those are the questions, right? All right. So here, come up with your answers for this. Okay, so here most of you think, let's see. Yes, most of you think it's answer A. There are few people who think it's answer C as well. Okay, so this is also another very commonly tested area actually. A case of pinpoint PUP. Okay, so this is not the first time that we are encountering this case. So pinpoint pupils, 18-year-old girl coming unconscious. She has pinpoint pupils. Now, before I go through the answers, just remember this. Now, these are like the 4 P's for pinpoint pupils. Your P painkiller, phosphate, PONS, and pilocarpine. So, painkillers, your opioids and heroin, then phosphate, organophosphate, PONS, your pontine hemorrhage, and this pilocarpine. These are like the most common, like 4 P's of pinpoint pupils. This you should like remember by heart, however, in any way, because this is a very common area being tested, the case of pinpoint pupils. Okay, so when you go through, when you remember that, and when you go through the answers we have, now it's obvious. Okay, it's not amphetamine, it's not cocaine, it's not spironolactone, it's heroin, which is answer A. Okay, this is like the key area that you need to revise in this question, pinpoint pupils. Remember this, 4 P's. Okay, next one. Impetigo starts antibiotic went to school. Now, I told in the previous discussion as well. Now, the school exclusion is a very common question that you get for different diseases. The previous session we discussed, we had a case of chickenpox actually. Now we have impetigo. So, what do you think? Sorry, AB mean antibiotic. A, after all lesions will dry. B, 24 hours after starting antibiotic. C, 5 days after starting antibiotics. Okay. So here most of you, no, the answers are varied actually here also. Answer A, B, C. All three answers have been given. Now I have told you the reference for the school exclusion. Actually, I took you to that link in the last class, so I'm not going to take you there today as well. But I have anyway included the link. So you have when you go to that link, you have a table like this, which gives you like the school exclusion criteria for different infectious diseases. So this is your impetigo. The school exclusion is exclude for 24 hours after antibiotic treatment is commenced. And when you exclude, you have to exclude for 24 hours after antibiotic treatment is being commenced. And the lesions on the exposed surface should be covered with a dressing, actually, waterproof dressing. And then you have to wait at least until for 24 hours after antibiotic treatment is commenced. So that is like the criteria for school exclusion in impetigo. So when we go to our answer, after all lesion will dry is wrong. 24 hours starting antibiotic is the correct one. Answer B. 5 days after antibiotic is also wrong. Okay, so this I told you. Now this is a very important area. You will get a lot of repeated questions, impetigo, varicella, chickenpox, different diseases, like how long should you exclude from school? Okay, this is the reference link. I took you to this in the last record. You can go through this after the class and have an idea. It has a table like this for all the diseases. Okay, next question. Nurse concerned about Alzheimer's patient. They are very close. The patient is disoriented and does not remember her family or something. Only come to see this male patient who also has Alzheimer's. What to do? A, check nurse's concern. B, change the mail to another ward. C, inform family. D, do nothing. What are you going to do? When you have these type of questions, try putting yourself to that position and think of the most logical answer. Then your answer will be correct. So there's a nurse concerned about Alzheimer's patient. These patients are very close. Patient is disoriented and does not remember her family or family. This lady, she only comes to see this male patient who also has Alzheimer's. So there are two Alzheimer's. One lady, she is disoriented, and she also comes only to see this male patient. So nurse is concerned about that. They're asking, what are you going to do? Okay, most of you think we should go with answer A, that is check nurse's concern. There are few who think answer C, inform family, and few for changing the mail to another ward. Okay, now let's go through and there are few who thinks do nothing. Okay, nurse is concerned about Alzheimer's patient. They are very close patient. Okay, now one nurse this is the concern of the nurse. That is the most important thing you have to highlight here. Not the concern of your one. That means this is not an observation made by you, but a concern of the nurse. Nurse is coming and telling you this. And she has a suspicion about this patient because this lady is very close to this male. They are disoriented. And her concern might be that they might have an unnecessary relationship causing to different problems because they are disoriented. So what are you going to do? Now think of you in this position. Somebody is coming and telling you, this nurse is telling you, first thing that you have to do would be to see whether it's correct, right? That is the most logical thing. So check nurse's concern. Yes, that is actually the first thing that you have to do. Change the mail to another ward, not yet, because you haven't confirmed this. Informing the family is also not the first step. Do nothing is also not a good option because you have to do something. There's a big concern here. So the next thing or the logical thing that you can do is to check the nurse's consent. That is answer A. Okay. So whenever you have this type of, this is not the first time you get this type of questions. You will get a lot. In that situation, put yourself into that scenario and think of the most logical thing that you will do. That will be actually the correct answer most of the time. Okay, next one. Child with dehydration. What is the most important indicator of dehydration? A. Capillary refill time. B. Skin turgor. C. BP. D. Pulse. Okay, somebody is asking me to repeat the previous answer. Now, in the previous answer, others can respond to this question, the answer. So, in the previous question, we had a nurse who was concerned about an Alzheimer's patient. This lady, the nurse tells that this lady is disoriented, but she comes to see only this male Alzheimer's patient, and they are having an unnecessary or unwanted relationship. So they're asking, what are you going to do? Now, when you are in that position, whenever somebody has a concern, one of your juniors, actually not juniors, somebody are below you has a concern like this and tells it to you, the most logical thing that you would do is to check whether it is correct, to confirm or check whether it's correct or not. Then only you are going to take any action based on that. You are not going to blindly trust them and take any action. So that's why the correct answer, what to do, will be to check the nurse's consent. Answer A. So here, answer A, check nurse's consent. This will be like the most logical thing that you will do. And see whether it's a correct consent. Sometimes some people might come and lie to you based on their personal problems. So the most logical thing you would do would to check the nurse's consent. Okay, I hope I made it clear now. All right. It's not clear, just let me know. I will explain again. Okay. So here we have a child with dehydration. What is the most important indicator? Now there are varied answers. So let's go from one by one. Capillary refill time. Okay, capillary refill time is a very good indicator of dehydration. Actually, it tells us about the peripheral perfusion. So in dehydration, initially the peripheral perfusion is the one that gets impaired. So capillary refill time is a very good indicator of peripheral perfusion. So it's a very good indicator of dehydration. Skin turgor again tells you the perfusion of the skin. Skin is not a vital organ as such. So in dehydration, whenever somebody is dehydrated, the body will try to maintain the perfusion to the vital organs, and the rest of the organs will get a less amount of blood perfused. So skin turgor will reduce because the skin will get less blood. Blood pressure, now blood pressure we know even in shock, when a patient is in shock, it will take some time for blood pressure to drop. Actually, it's in stage 3 of the shock that blood pressure starts to drop. So blood pressure is out. Pulse, again pulse is, it will actually, there will be a tachycardia even in shock. And it will take some time for that as well. Usually in stage 2 of shock like only the tachycardia will be there. Now this is not shock. Shock is a severe form, but even in severe form, it will be around stage 2. So it can be normal in mild dehydration as well. Okay. So when you take A and B, now there's a problem. What is the correct one and why? Can anybody mention with the reason? There were a few who thought A, not few, significant number who thought A. Some people thought B as well. Can somebody mention with the reason what do you think is correct? Very good. Excellent. There is one answer. Dr. Tillini, I think. If the child has more adipose tissue or, obese child, skin turgor, different interpretation will be difficult. Very good. That is one thing. Next one, severe dehydration. Now, skin turgor will be like skin turgor is a very subjective thing. You are taking a skin picture and checking whether it's like the skin recoil is there. For it to become like significantly impaired to a level that you will detect it, it will take a long time. But capillary refill time is not is a bit objective than this skin turgor, and you can usually easily detect it early. So it is the most important reliable indicator. Next thing is, since skin turgor might be impaired in different other skin diseases as well. Okay, so because of all those reasons, capillary refill time is the most important indicator rather than the skin turgor. So the correct answer is answer A. Okay. Next question. Hypersegmented neutrophils, macrocytic anemia, thrombocytopenia, lymphocytes low. What is the diagnosis? A. Pernicious anemia, B. CML, C. Blood loss, D. Another microcytic cause had been given. Okay, most of you think it's answer A. Okay, let's see. All right, let's go through this. We have a case of macrocytic anemia with thrombocytopenia and low lymphocytes. And we have hypersegmented neutrophils. Now, this is very straightforward, right? So, first, this is obviously a macrocytic anemia. So, answer E, D is out. This can't be another microcytic cause. Blood loss usually gives rise to normocytic anemia. Now, in CML, you can have a component of anemia, but it is not obviously microcytic usually, and you don't have these other findings of hypersegmented neutrophils as well. So your answer of answer A, pernicious anemia, is actually very correct. So this is the blood picture film of a pernicious anemia. You will have oval macrocytes, hypersegmented granulocytes, and anisopoikilocytosis. Okay. Then in severe anemia, you will have this Havel jelly bodies and Cabot rings, punctate basophilia, these features as well. But you will not usually get these in exams. Usually this hypersegmented granulocyte is a very common thing that they test whether you know. They are in most of the megaloblastic anemias as well. Okay, so anemia is another very common area where you get questions. Now they will give you different types of anemia scenarios of microcytic, macrocytic, and different types of scenarios, and test your knowledge on how do you like approach those patients. So this is like your Bible for anemia management, diagnostic and management strategies for anemia in adults. Again, an RACGP1. They have nice case like sort of a thing. Then you have the reference values you usually get in the exams. Then you have the differential type diagnosis of different types of anemias. Macrocytic anemias. Then you have this list of features: hypersegmented neutrophils, Haynes bodies, Havel-Jolly bodies. When do you get these different types of blood picture findings? You have a nice table with that there. And then you have like nice cases. You have different types of anemia, like how do you diagnose and how do you manage. So it's like a nice overview of anemia in a form of cases, actually, with important things as well, important diagnostic and management principle. The most like the thing that I like most about these articles is now these are relevant to the practice and these are guideline based and these are very nice short ones, which is very easy for you to go through and to understand. Only 5 pages. Okay, so if you need more like information on anemia and if you're not very sure, you can go through this and have a look. Okay, patient has calf pain and after walking a distance. He is also non-diabetic, has features of peripheral neuropathy bilaterally. Reduced ankle reflex also. Ask the cause of calf pain. A, peripheral arterial disease, B, diabetes, C, varicose vein. This question was there in different formats. There was another format there. It was stated only about absent ankle reflexes. Nothing about this peripheral neuropathy. So let's go through these and see. Okay, so let's see, what do you think? Answer A, is there peripheral arterial disease? Answer B, diabetes is also there. Answer C, varicose vein is also there. So the answers among you are divided actually. So let's go through this. Here you have a patient with calf pain after walking a distance. He is also a non-diabetic patient. He has features of peripheral neuropathy and reduced ankle reflex also. Ask the cause of calf pain. Okay. So what is the term for this pain? Patient has calf pain after walking a distance. Is there a term for this? Pain after walking a certain distance. Yes, very good, excellent. Intermittent claudication. So that is your claudication pain. Now rest pain is something different. Rest pain you usually get at night and it's relieved by when they are sleeping, actually sleeping, or when they are like on the bed lying, and it is relieved by putting the leg down. So that's rest pain. Now this is claudication or your intermittent claudication that you get after walking for a distance. Now this is a very important finding, very classical finding of your peripheral vascular disease or peripheral arterial diseases. Okay. So now when you take this case, this patient is having intermittent claudication. He has diabetes as well. Now you know diabetic can give rise to this intermittent claudication or peripheral arterial diseases. Now he has peripheral neuropathy, that is because of diabetes. Reduced ankle reflexes is also a part of this peripheral neuropathy. So if we summarize this case, this is a patient who has diabetes complicated with diabetic peripheral neuropathy, now coming with calf pain after walking a distance. They are asking the cause of calf pain. Okay, the cause of calf pain. Now varicose veins is out here because nothing is mentioned about varicose vein in this case. When you take peripheral artery disease, that is correct because intermittent claudication is like the pathognomonic finding of peripheral arterial disease. Some have voted for diabetes. Now, we can tell us diabetes causing peripheral arterial disease causing intermittent claudication. Actually, that is the correct way of this happening. So they have asked the cause of the calf pain. So the cause of the calf pain, you have to now go for the immediate cause here. So the immediate cause would be the peripheral arterial disease, which is answer A. But this peripheral arterial disease might have been caused by diabetes because he's a known patient with diabetic complication. So this is a diabetic macrovascular complication actually starting to develop. So that's why some of you might have thought of answer B as the correct answer. But don't worry about the answer here because they have asked the cause for the calf pain. The immediate cause we can take as answer A. But if you thought as answer B, don't get disheartened. That's also correct in another way. So don't, as I told in the first day, don't worry about getting the answer. Just understand the principle because the questions in your exam will be very clear. They will not have confusing answers like this. They will not have confusing things like this in the halfway thing. So they will be very clear and they will be to the point. So you don't need to worry about that, but understand the principles. So here, because of they asked the cause of calf pain, we are going with answer A. Okay. Next up. Long scenario about cryptogenic organizing pneumonia with Mason bodies asking for treatment. A. Dexamethasone. B. Ciprofloxacin. C. Doxycycline. Can you explain how diabetes causes this? Okay, diabetes can cause peripheral vascular disease is can be a complication of diabetes, a macrovascular complication of diabetes. So because of the peripheral vascular disease caused by diabetes, he can develop intermittent claudication. Diabetes can be a risk or root or the etiology of that. But this leg pain is due to intermittent claudication. Okay, diabetes can be the etiology of that. So what do you think for this? A. Dexamethasone, B. Ciprofloxacin, C. Doxycycline. Okay, so most of you think it is answer A, dexamethasone. Actually, that's very correct. So whenever you have cryptogenic organizing pneumonia, your treatment is dexamethasone. That is very correct. Now I'll take you to that. Can anybody mention to what category of lung diseases does the cryptogenic organizing pneumonia belong? Yes, excellent. That is an ILD, interstitial lung disease. Now this is actually a repeated one. We have seen this being asked previously as well. So just have an idea of this. So this is your reference for interstitial lung disease. Now you have a wide range of interstitial lung diseases. Now here you have the investigations and what do you find in these investigations? You can see it. Then you have the classification scheme. You have varied types of interstitial lung diseases of unknown ILD of known association, granulomatous, idiopathic interstitial pneumonia, miscellaneous IED likewise. Now your cryptogenic organizing pneumonia belongs to idiopathic interstitial pneumonia. You can see it here. Okay. Then you have different classification of these pneumonias and you have like the findings and the management of these different types of pneumonias. Now here you can see your cryptogenic organizing pneumonia. This is of actually uncertain etiology. And it is associated with malaise, fever, and cough, like in other pneumonias. It has a good prognosis with excellent response to systemic corticosteroids. Actually, it's the steroids that we use as the treatment for cryptogenic organizing pneumonia. Now, this gives you an overview of other types of ILD and the management of different types of ILD as well. That's only this. So it's also a very short article, but gives a nice overview of ILD that you can refer later. So here you have the answer dexamethasone, which is a steroid, which is the correct answer for this question. So not ciprofloxacin, not doxycycline. Okay. Next one. 68-year-old man developed right-left confusion, apraxia. He cannot write an Edo substract. Where would be the likely lesion? Okay, let's see. Most of you think it's... No, the answers are varied among A and B. Let's see. So this is again another common area that is being tested. That is whether you know the different lobe functions of brain, like to what each lobe of the brain is involved. So this is like just a summary. Frontal lobe, just remember, as mainly involved in your personality, emotions, those type of a thing, and judgment, those things. So whenever you have frontal lobe lesion, they have like disinhibition. They remove their clothes in front of everyone, those sort of a thing. Then your temporal lobe, mainly your language, memory, hearing, learning, those things. Parietal lobe, it is for your perceptions and spatial perception, visual perception, arithmetic, academic, maths, calculations, those sort of a thing. Occipital lobe, mainly visual. Cerebellum, mainly coordination. Brainstem, mainly reflexes. So that is like the basic overview of different lobes. Now you have a detailed account here. Having said that, now we have a 68-year-old man developing right-left confusion, apraxia. He cannot write Edo substract. So now you know with all these features, right-left confusion, apraxia specifically, writing, addition, mathematical, academic skills impaired. So the likely lobe that is involved is your parietal lobe. So left temporal is out, answer D is out. C, right temporal is out. But we are left with two answers, right parietal, left parietal. So how do you determine whether this is right parietal lobe or left parietal lobe lesion? Can anybody mention? Because we know parietal lobe, but sides are given. They have not mentioned about any side impairment in the... So how do you tell whether this is right parietal lobe lesion? Excellent, Dr. Anu. Dominant lobe. That concept of dominant lobe is the one that is important here. So you usually consider that left parietal lobe is the dominant one because we usually consider the majority of the population are right-handed and left parietal lobe is the dominant parietal lobe in them. So having said that, we can mark the answer as answer B, which is left parietal glioblastoma. But it will change if this is a left-handed person, or if the dominant parietal lobe is different. So, but because of that basic norm or basic knowledge that we have, the lesion, left parietal lobe is the dominant one. So the lesion should be in left parietal lobe. Okay, so this question tells you that you need to know the knowledge. You need to, now dominance, of course, no, everybody of all of you will know that, but you need to know the lobe functions. So just have an idea of the different lobe functions of the brain as an overview. It's a summary. Okay. Picture of abdominal cellulitis while on flucloxacillin worsening. They have asked for management, look like necrotizing fasciitis. Next step. A daily gentamicin, B surgical debridement. What do you think? This had only 2 options, but the original one you will have a lot of options actually. Okay, it seems an easy one to all of you. All of you think this is answer B, which is actually correct. So whenever you have a case of necrotizing fasciitis, you know surgical debridement or surgical management is like the keystone or cornerstone, because this is a surgical emergency. Okay, this has also been asked several times. This is not the first time. Several times in the previously as well. So better have a good understanding about the necrotizing fasciitis. Again, just as a guidance, I am showing you the reference material for denecrotizing fasciitis. Now, I am showing these things just as a guidance because some of you might not be knowing like where to refer these things. That's why I am showing it so that you will go through that. Now, this is a nice overview, actually of only of 3 pages of necrotizing fasciitis. Now, they have given you like the diagnosis, management, and the risk factors, investigation findings, and the management. Now, surgery is the key management strategy because it is a surgical emergency. Okay, so this is like a very simple overview of necrotizing fasciitis, which you can go through leisurely. All right, next one. 3-year-old with upper respiratory tract infection, temperature 38.2, abdominal pain, vomiting and nausea. Chest X-ray shows right mid-lobe consolidation, not consolidation, consolidation, positive organism. What do you think? An easy one, but an important area. Again, a repeated one from the previous times as well. So that implies that this is an important area for your reference. Okay, all of you think it's answer B. Actually, that's very correct. So this case test whether you have understanding of the etiological agents for different types of pneumonia. Now, when you have a case with pneumonia, age is very important. 3-year-old with fever, vomiting, chest X-ray shows right mid-lobe consolidation. This tells us this is a lobe pneumonia or community-acquired pneumonia. So they are asking you what is the most common cause for community-acquired pneumonia in a 3-year-old. For that, you need to know like this. Now, for children, you have like different common etiological agents for different ages actually. Now, ignore this treatment. It will differ actually. Just focus on the pathogen. For neonates, for 1 to 3 months, and then for younger than 3 years, older than 5 years. So for this is younger than 5 years. This is a 3-year-old child. Streptococcus pneumoniae becomes the most common etiological agent for lobar pneumonia in a less than 5-year-old child. But it is different for a neonate. It's mainly group B streptococci, E. coli, those things which are like the organisms that are commensals of maternal vaginal or maternal genital tract. So just remember that based on the age, you have different causative agents. Now, this has been tested previously by asking the antibiotic without asking the organism. So then again, it's like you need to know the organism for that age, and then you need to know the antibiotic you are using. So they can either ask the organism or the antibiotic. So be prepared for both. So here your answer is correct. Answer B, Streptococcus pneumonia. Okay. Moving on. An old man with low valent cellulitis treatment. Another very common area. A, flucloxacillin, B, amoxicillin, C, vancomycin. Now don't expect the question to be this simple. You will have a big scenario with features of cellulitis, like a long history. You should identify that this is cellulitis from that history, and then they will ask for the treatment. Okay, so it is not as simple as this, but you should know the management. Very common area, cellulitis management. Okay, so okay, there's a question by Dr. Shabab. Yes, they are from March. Actually, from March. All right. So let's see. Most of you have answered as answer A, flucloxacillin. So this is your guideline for bacterial skin and soft tissue infections. So here you have different types of soft tissue infections, your boil, folliculitis, cellulitis, and everything. And you have the different types of treatment options. You have the likely pathogen and the management. For impetigo, boils and carbuncles, folliculitis, cellulitis, erysipelas, periorbital cellulitis, orbital cellulitis, necrotizing fasciitis, those things. Okay, so you can go through this leisurely, and they have like a different description of these diseases as well. So for cellulitis, like all of you have mentioned, the commonest or the most important treatment that you have to give would be flucloxacillin, which is answer A. Okay. Next one. Patient having some disease, GP wants to see how many more will have the disease in the broad population. A, case control, B, cohort, C, cross-sectional. Okay, now here the answers are varied actually. Patient is having some disease. Patient is having some disease. GP wants to see how many more will have the disease. For example, one patient is coming with, let's take malaria. Then GP wants to see how many more will have this disease in a broad population. So how many more are having this disease? So whether it's case control, cohort, or cross-sectional. Now let's go through the different study designs, because again, statistics is very important area, and this different research study designs is also an important area for that you should have an understanding. So this gives a nice overview. Now you have your descriptive studies and your analytical studies. Now analytical studies, you have three broad arms actually. Your cross-sectional studies, case control studies, and the cohort studies. Now when you take the differences in, now this gives a nice overview of everything. Now cross-sectional study means you are taking a timeline. That means now you are conducting it tomorrow. It's a very easy one. You are just taking a population and you are taking, okay, prevalence of malaria in this community. Then you are taking that population and you are checking how many have the malaria, and then you are later studying on the risk factors and the risk factors and the outcomes and everything. So at a given time, you are checking that. So that is cross-sectional in simpler terms. In a case control, you are doing it backwards. So you are just, it is usually checking the exposure and the outcome in case control. So they are backward directed ones. So you are taking, for example, you are checking the impact of some nutritional or some impact of sunlight on melanoma development. So then you are taking a number of patients who have melanoma. You are working backwards to see how much sun exposure they had, and you are calculating it like that. Cohort will be different. So cohort, you are doing it in the other way. So the same thing, it's impact of sunlight on melanoma. You are taking two groups of people. You are controlling the sun exposure. Now you can't do that, but I'm just giving an example. You're controlling the sun exposure into control group and the case group, and then you are following them up them for some period, some duration, and then you are checking whether they develop melanoma or not. So that is cohort. So that is like the major overview of the three different types of studies. You have it nicely here. Okay, so now here this GP doesn't want to see any association of risk factors or anything. He just want to see how many more will have this disease in his population. So he doesn't need to go for a case control. He doesn't need to go for a cohort. A simple cross-sectional study would be the most ideal thing for his purpose. So answer would be answer C. Okay, just learn the difference of these three. Three are analytical study types. Okay, next one. Patient with epigastric pain. Nothing about radiation of pain. Nausea, BP 90/60. Heart rate 100. Epigastric tenderness and guarding. Few days before, he has some little pain. Investigation. A. Lipase. B. Erect X-ray chest. C. Supine X-ray chest. Now, this patient is coming with epigastric pain. BP is this, heart rate is this. Epigastric tenderness and guarding are there. Okay, so here some of you think it's answer A, some of you think answer B. Okay, so what is the most, again I'm asking the same thing because I'm asking that to make you used to like how to work this question. What is the most important most striking clinical feature here that will determine your answer? Can anybody mention? Excellent, Dr. Tilini, very good. Guarding. Okay, so this is like the most striking feature that will determine your investigation. Now he is coming with epigastric pain, nothing about radiation. Now see the BP, it's bit towards low side. Heart rate, there's a bit of tachycardia. Epigastric tenderness and guarding is there. Few days ago he had some little pain. Now he's coming with this pain. So whenever you have a patient with guarding rigidity, you are suspecting whether there's a sinister pathology. Okay, and the BP towards low side, there's a bit of tachycardia. So you're wondering whether this is going to be an acute abdomen, whether there's a sort of a perforation or anything as such. So when I told you, whenever you have this type of a case, when they ask for the next investigation or some sort of a thing like that, you have to always exclude the most severe or tragic cause, because that will make you a safe doctor. So here this could have been a pancreatitis now developing to something sinister. Lipase will tell you whether this is a pancreatitis or not. But with this guarding, low BP, heart rate and everything, you have to exclude some intra-abdominal perforation or any sinister pathology as such. For that, you need to get the erect chest X-ray to be that safe doctor. And you have to exclude that because this clinical profile is a severe profile, not like a mild epigastric or not just a pancreatitis. So you have to do erect chest X-ray to exclude this, whether there's gas under the diaphragm. And then if it is not there, you are safe and you are happy, then you can move on with your next investigation to find out the cause. So answer will be answer B. Okay. Next one. 20-year-old male, small patch hair loss on scalp, history of atopic eczema, normal skin on dermoscopy, short hairs, tapered appearance, diagnosis. For which condition we are doing supine X-ray? Okay, that's a good question. For which condition do we do supine X-ray? We usually do it when we suspect intestinal obstructions mainly. And when the patient can, now we are not doing supine chest X-ray, supine abdominal X-ray to exclude any perforation. It cannot actually. It is usually done if you suspect intestinal obstruction, those things, because it's patient, and in a patient who is bedbound and you have to look for bowel pathologies, you can do it supine X-ray, but you can't exclude perforation by that. Okay. So here most of you think it's answer A, which is alopecia areata. Okay, now 20-year-old male, small patch hair loss on scalp, history of atopic eczema, normal skin on dermoscopy, short hairs, tapered appearance. How do you call this appearance? Can anybody mention short hairs with tapered appearance? Excellent, Dr. Anu. Exclamation mark hairs. Very good. Okay, so this is exclamation mark hair. So like this, like an exclamation mark, the hair is there. So let me just tell you, this is folliculitis decalvans. Now this is a sort of scarring alopecia. There is associated scarring. And they will have hair loss with scar tissue formation, and permanent hair loss will eventually result. Okay, so this is folliculitis decalvans. Then chirion, I think most of you must be knowing. Chirion is this. Okay, and then let me take you to your alopecia areata. Now, this is the article about hair and nail. It gives a nice overview of different hair and nail disorders. Now, your alopecia areata is this one. I don't know whether you can see the exclamation mark clearly here. Okay, this is how you see this alopecia areata. Then you have your other scarring alopecia, and this follicularity decalvans is also there. So in alopecia areata, this picture is not very clear, but when you Google it and see, you can see that exclamation mark hair is there. Now this also gives you nail disorders, onychomycosis, etc., which you can leisurely go through. So this case history of atopic eczema is also supportive of alopecia areata because they can have associations. Short hair, tapered appearance, everything will help this. So this answer, your answer is correct. Answer A, alopecia areata. Next one. Looks like a Bartholin gland cyst, patient in severe pain. Initial step. A, pain reliever. B, marsupialization. C, word catheterization. D, antibiotics. E, excision. Now you know you should differentiate initial step, best step, next management, best management. So they're asking for initial step. Okay. Most of you think it's A, some think it's C. Okay, let me take you to the management of Bartholin gland cyst. This gives you a nice overview. Introduction, etiology, pathophysiology, everything is there simply. And when you take it to the treatment, asymptomatic ones, you don't need of any drainage as such. But incision and drainage with word catheter is as the first step, like first cleaning management that we give. Then incision, once you cannot do that, you are considering marsupialization at actually a theater or a theater setup. Antibiotics also indicated, you give that as well. And there are other procedures as well, which you can leisurely go through. Okay. So when we go to our case, we have marsupialization, which is a management option actually. But it is done at a theater setup or somewhere when we cannot do word catheterization. Word catheterization, we usually do incision and drainage with and word catheterization. That is there. Antibiotic is there. Excision we are not going to do. We are doing IND with word catheterization as the initial step. But here, see the case. Looks like a Bartholin gland cyst, patient in severe pain. Initial step. Okay. So this patient is in severe pain. You are not going to do any of this without attending to patient's pain first. He is in severe pain, not a mild pain or anything as such. So your initial step should be giving a pain relief. And then you are going to do this IND with word catheterization and give antibiotics and everything. Okay, so your answer is correct. Answer A, which is pain relief. Go through this article and have a good overview of life management. It's usually that. Okay, next one. Pregnant women with preeclampsia present with right upper abdominal pain due to A, pancreatitis, B, cholecystitis, C, gastric ulcer, D, tension of liver capsule, E, esophagitis. They are asking the cause of right upper abdominal pain in a pregnant woman with preeclampsia. This is a easy question. Yes, your answer is correct. Most of you think it's answer D. That's very correct. This is actually theory. This right abdominal pain in preeclampsia is due to this tension of the liver capsule. So answer D is correct. It's not due to pancreatitis, not due to cholecystitis, not due to gastric ulcer, esophagitis. Now all of these can give rise to upper abdominal pain. But here in preeclampsia, it's due to tension of liver capsule. Okay. Bimanual pelvic examination reveals cervical tenderness. Cause A, missed abortion. Cervical, this must be motion tenderness actually. B, threatened abortion. C, ectopic pregnancy. D, molar pregnancy. E, normal pregnancy. Okay. So most of you think it's answer C, which is ectopic pregnancy. That is actually correct. Why? Because you get this cervical motion tenderness is like a very pathognomonic, we can't say actually pathognomonic, very common finding that you get in ectopic pregnancy, because here the pregnancy is outside the uterus, so they can have this clinical feature. Now, missed abortion is wrong. Threatened abortion is wrong. Now, you don't get cervical motion tenderness in these. Molar pregnancy wrong. Normal pregnancy wrong. So all of these are like more or less similar to like intrauterine. All of these are intrauterine ones. Ectopic pregnancy is the one which can cause cervical motion tenderness. So answer C. All right. So I think we have we have finished on time today. Actually, we have finished on time. So I hope you learned something. We covered a lot of area today as well, like in the previous one. Okay, there's a question. Will these topics discussed during theory class? Yes. That's why we are not going to go into deep in the MCQ classes. Because in the MCQ discussion, if we discuss them, you will not be able to discuss a lot of sample MCQ. You will have theory classes. Each of these topics will be covered in them. So now you are starting, you have a long way to go in theory classes. So once you get them done, you can learn them. I'm giving you the references so that you can go through that. Will the PowerPoint upload on portal? Yes, we will upload the note as well as the recording both. Can you please suggest how to utilize the question solve class? Or after question solve class, what to do? Okay, so the way to utilize that I would suggest would be to do the questions. Now I give you about few seconds, put the question, and then not only me, the other mentors will do the same. They will give you some time for you to come up with the answer. So take it as an exam or some sort of a preparation, some sort of a live exam, and try answering and see whether you can remember them or whether you know them. So if you do that, then you can come to an understanding of like what are the areas that you are lacking. So if you try it, if you get it correct, you know you are okay with that area. If you get it wrong, mean you know you should have more idea about that area. So one way to utilize them would be to like take it as an exam then and there and do it as much as possible. Try to answer all the questions. Second thing would be to go through the note and you will be like, we will be giving you the links of the references. Those are actually good resources which will help you to guide for your exam. So go through them and make your own notes or make a summary and keep it for your future references, because you will definitely need them for future questions and everything. So that would be another way of utilizing them. Okay. Is it necessary to go through all those articles? Not necessary. If you already have a good knowledge, if you have a good note, no need. If you don't, we are giving it as a reference for those who actually don't have an idea and those who needs to get more knowledge or to have a basic overview, we are giving the link. But if you have already have a good understanding of the topic, no need to go through. Okay. I didn't get why it was right parietal glioblastoma. Why it was not right parietal glioblastoma instead of left? That is because usually the parietal lobe functions are by the dominant parietal lobe. So we consider left parietal lobe to be the dominant in majority of the patients, because most of them are right-handed, and we consider, and not only because of right-handed, left parietal lobe as the dominant parietal lobe for the functions. So because of that only, we are taking left parietal lobe as the answer, because it is the dominant one in most of the population. But if it was given that his dominant parietal lobe is right, then the answer should be right. Okay, I hope it was clear. All right, so I addressed almost all the questions that you have asked. All right, so we'll end the session for today. Thank you very much for joining today and for your interactive participation. You will meet again in another session. Okay, so thank you and all the best.